Hello, everybody, and welcome to this Boston Scientific sponsored session entitled Complex PCI in Coronary Calcified Lesions, the Right Tools and Techniques. Together with me, I am Flavio Luciano Ribichini, the chairman of the cardiology division in Verona. We have a Professor Akiko Maehara from the Columbia University in New York. Hello, Akiko. Thank you for being with us. Dr. Colm Hanratty from the Mater Private Hospital in Dublin, who is actually the operator of the case we will see together. Professor David Leistner, director of the interventional cardiology in Berlin at the Charité University Hospital, and Emile Mehanna from the Lebanese American University Medical Center, who is our chast master. So how this will work? Emile will be catching your questions, so I encourage you to make through the chat system all the questions that you'd like to address if we were together, as we used to be. And we will present you a case that has the following learning points. First, and above all, we will see the importance of intravascular imaging in the decision-making process of a treatment of a complex coronary artery disease involving the left main. This is very nice because despite the angiographic imaging, we will discover some secrets inside the vessel that we could not see if not thanks to the intravascular imaging. The other objective of this case is to discuss how to manage these imperfect stentings or calcified plaques that we may have inside the vessel, and then to learn about a new drug-eluting stent, which is a new purpose-built stent for large vessels, which is the Megatron Boston Scientific stent. So this was the quick introduction. And so we will start with Akiko. She will share with us her huge experience on intravascular imaging in calcified vessels. So we start with you from New York in a recorded interview.
Let me talk advanced IVUS assessment of coronary calcium. So the first, we have to differentiate superficial calcium versus deep calcium. Angiographic appearance could be similar. Deep calcium does not inhibit stent expansion, and superficial calcium does inhibit stent expansion. And calcified nodule, irregular surface, and accumulation of small nodular calcification, this is really indicate the chunk of the deep calcium behind. And this is a comparison between the angiographic calcium versus IVUS calcium. In general, if you have moderate or severe angiographic calcium, that's indicating large calcium by IVUS. But sometimes angiographically non-calcium, but we can see the big calcium by IVUS. So this is a case example in such. In the distal right coronary artery, there is a no calcium by angio, and by IVUS, you see the big calcium. In same case, we did the OCT, and you can see that calcium was actually quite thin. So because of the angiographic calcium, depends on the total volume of the calcium. So if the calcium is thin, even large, they are not visible by angio. In other words, if you don't see the calcium by angio, but you see the big calcium by IVUS, that's indicating most likely thin calcium. This is a comparison between the IVUS appearance and OCT calcium thickness. And this is so-called IVUS loop ablation. And you can see the second layer, which is the artifact from the surface calcium. And we call this is loop ablation. And if you see this type of the loop ablation, those calcium more likely indicate thin calcium measured by OCT. Therefore, if you see this type of the loop ablation before any treatment, you can consider this probably thin calcium. But please consider this is not 100% correlation. Therefore, please use this information as your reference. And this case, we did balloon and stent And you can see the nice calcium fracture. And how you can identify the calcium fracture? You look into the behind, meaning before fracture, because of the calcium, you don't see any tissue behind. But after the fracture, you see the tissue behind. That's indicating no longer calcium present. So that's a way to recognize the calcium fracture. And this case, we have the calcium fracture here and here and here. There is a multiple calcium fracture, giving us the good stretching of the vessel and then good stent expansion. So this is quite important to recognize calcium fracture before stenting. And retrospectively speaking, because this calcium was fractured well, only the balloon and stent, that's probably thin calcium. So based on those information, we developed the calcium score. And this is a component of the calcium score. And what is important is big, long calcium, such as calcium angle more than 270 and longer than 5 millimeter. And circumferential 360 degree of the calcium is very important, which is very different compared to non-circumferential. For example, this calcium is big, but non-calcium segment can make the good dissection. That's very different compared to the circumferential calcium. And calcified nodule is very important. This is really the marker of the big chunk of the calcium plate behind. And finally, the vessel diameter is important. Even the calcium lesion, you should look into somewhere which you can measure the vessel diameter. And if the vessel diameter is less than 3.5, you start with small vessel and you have less capacity to stent expansion, therefore more likely under expansion. First, we ask, can you see the angiographic calcium? And if yes, we have to calculate the calcium score. If no, most likely those calcium is thin, therefore this is okay. And if the calcium score is more than or equal to 2, we recommend to do the atherectomy. This is very clear interaction between the calcium score and treatment effect. And even the high score, if you do the atherectomy, you can get the good stent expansion compared to without. And how we can identify the effect of the atherectomy using the IVUS. And actually quite similar between the rotablator and orbitory. The first, you should look into where the IVUS caster is located, because those are the place where the wire bias, and also those are the place where the atherectomy was located. And if you see the nice reverberation at the site of the IVUS catheter, that's indicating atherectomy making the nice polishment of the surface of the calcium, making nice reverberation. This atherectomy, I see the nice reverberation, and this rotablator, I see the nice reverberation. So this is really nice effect of each device. And typically, at the site of the reverberation, we can see the nice calcium fracture. I can see the fracture here. I can see the fracture here. So those are the effect and confirmation by IVUS. And it is very important to confirm this type of the effect and this type of the calcium fracture before stenting, because that's secure, you can get good stent expansion. The only difference which we see between the rotablator and the orbitory is orbitory can make the good effect, even the big lumen area compared to rotablator. Finally, this is a data in terms of the neo-atherosclerotic calcium, meaning there is an old stent here indicating by yellow arrow, and you can see the calcium inside of the stent. This is really newly developed atherosclerosis and calcium in the stent. This is a data based on our data including about 300 in-stent restenosis based on the second generation DS. And if the stent failure more than 5 years, the rate of the neo-atherocalcium is about 40%, which is not a rare phenomenon. And how can we predict stent expansion in the neoarterial calcium is really similar to the de novo calcium, such as large, long calcium that's indicating poor stent expansion. Therefore, you have to evaluate those characteristics, and if so, you have to prepare before stenting. Thank you very much.
Thank you very much indeed, Akiko. This is excellent. I mean, so clear with such nice images. We all have to learn from your talk. I will make two brief questions. One, it's to David. David, you have seen how clearly Akiko demonstrated the need of using an atherectomy device when the calcium score says is more than 2. How often do you use this in your clinical practice?
I think this is a really great question because it brings one topic of Akiko's talk also in the center. This is that there is a mismatch between the evaluation of calcification by angiography and by intracoronary imaging. So to answer this clear, in my daily routine, I do such a extensive debarking of stenosis in about 5 to 10% of the cases. But, and this is exactly the point, the more image you do, the more lesions you will find where you need such a lesion debarking. And this is what's clearly nice shown by Akiko, that there is a mismatch and that you have to use intracoronary imaging to detect such lesions.
Good. Same question to my friend Colm. You will use imaging in your case, but this is a recorded case on purpose for this session. Be sincere and tell us how often you use it in your clinical practice when you see some calcium in the angiogram.
Yeah, and I think we're moving towards one-to-one predilation to test the compliance. So certainly if you predilate a lesion with a 3035 balloon and you get a waste, that demonstrates you've got calcium, and imaging is mandatory. The other things that we should probably touch on when we've learned from the imaging and the thickness of the calcium, the size of the vessel, we've got several modalities now for modifying calcium, whereas previously we just had rotablation. We now have cutting balloons. So if you've got a large vessel, thin or eccentric calcification, then cutting balloon works very well. If you've got a large vessel, concentric calcification, which is deep, shockwave IVL works well. And these treatments are fitting into an algorithm, and they're all complementary. And I don't think we should fear any of these technologies, but paramount to the decision making is the imaging. And if you're going to use expensive, potentially complex technologies, then the imaging is critical to understand which technology and when to apply it.
Okay, Akiko, for you, the last and very short, but very important, you show that the very long term after stent implantation in calcified plaques, we have neoatherosclerosis and we have restenosis. This is not the typical restenosis process that happens 3-6 months afterwards. Is that different process in calcified plaques?
I don't think so. Only things which different is timing, meaning that the novel calcium developed almost 20-30 years after the bone, but this type of the neoarterial calcium even developed even 2 years after the stenting, so just timing is too quick. But when you look into the real picture, the appearance is similar, but I do think distribution is slightly different. We see more concentric calcium in the neoarteriosclerosis compared to the de novo, because start with the neointima, that's usually concentric.
Okay, so you would not be so concerned in leaving an asymmetrically deployed stent, but rather to treat circumferential lesions.
Correct.
Good. This is why we need good devices to cope with that, because it's still a major limitation for endovascular therapies on revascularization. Good. I think that we are all ready to start with the presentation of our case today. So I will ask, please, the technicians to run the presentation video prepared by Colm.
Thank you for the invitation to share this interesting and complex case with you, the remit being complex PCI in calcified coronary disease. These are my potential conflicts of interest. So this very interesting case of a 59-year-old lady who presented this year with exertional angina. She underwent a stress MRI which demonstrated ischemia predominantly in the lateral wall, but also in the apical wall. So the whole anterior wall is ischemic. She has a remote history of PCI. She underwent intervention in 2013, where she had a stent deployed at the ostium of the circumflex. She returned with symptoms in 2016. At this time, there was disease at the ostium of the LAD. This probably related to the procedure in 2013, restenotic process. And she had a stent implanted from the left anterior descending artery back into the left main. It's worth mentioning that neither of these procedures were image guided, and that on the 2016 procedure, the operator did mention difficulty with recrossing into the circumflex, and there was not a kissing inflation performed. So this was a case that we performed in Dublin with my good friend and colleague, Dr. Mark Kennedy, at the front end. This is a 7 French radial VL guide with a wire in the left anterior descending artery. And so we'll let the angiographic appearances play, and then I'll give you some close-ups. Angiographically, I think it's worth saying that it doesn't look very complex. You can see the left mainstem, the left anterior descending artery. Your attention is drawn to the circumflex artery, and certainly it looks quite innocuous in terms of angiography. Remember, however, this lady has exertional angina and an MRI demonstrating ischemia in the lateral wall and the anterior wall. So the first thing we did was we did intracoronary imaging from the left anterior descending artery back into the left mainstem. And what you'll notice in the left anterior descending artery stent, the distal part looks quite good. As you come back into the left mainstem, you'll see the stent is floating and malopposed. And then there's a defect at 6 o'clock on the image to the left, where the stent looks to be compressed. The left mainstem is a 5 millimeter vessel, as you would expect. So the left anterior descending artery distally looks good. There's malopposed stents in the left mainstem. And then there is a crushed stent down at 6 o'clock, proximal to that, which I think represents that old circumflex stent. After predilation, we performed IVUS from the circumflex back into the left mainstem. You can see the distal circumflex stent actually looks well sized, well opposed. And then in the left mainstem, you can see there is a stent from 9 o'clock round to 3 o'clock, but no stent on the lower surface of the artery. You can see the long view, which looks quite good, but there is an area of interest at the ostium of the circumflex. So to summarize, the distal circumflex stent looks good. There is partial stent in the left main stem, suggesting that there's been a longitudinal stent deformation. That's probably the LAD stent. And the long view demonstrates this area of interest at the ostium of the circumflex. Quite interestingly, remember this is after predilation to get the IVUS catheter, there is considerable disruption to the stent in the ostium of the circumflex. There is deep calcium beyond the stent. The diameter is 2 millimeters at the ostium of the circumflex. So as I said, there's significant calcification of the ostium of the circumflex. The stent is grossly undersized and underexpanded, with an area of about 5 millimeters squared at the ostium of the circumflex. So in summary, we have a young lady with a left mainstem equivalent, certainly in terms of ischemia and mechanically. The first thing to point out is the angiogram looks very unimpressive, and that highlights the importance of intracoronary imaging in these complex cases, because when we performed intracoronary imaging, we demonstrated that the distal left anterior descending stent looks quite good. However, it's grossly malopposed in the left mainstem, and then there are crushed layers of stent in the left mainstem, probably the circumflex stent. Circumflex stent looks satisfactory distally. There's considerable constraint at the ostium of the circumflex artery due to calcium. This was not modified prior to the implantation of that stent previously. And then we have a longitudinal stent deformation of the left anterior descending artery stent in the left mainstem. In terms of discussion and asking the panel, how are we going to manage this? We've demonstrated on intracoronary imaging there's a malopposed stent in the left mainstem. There are crushed layers from an old stent in the left mainstem, probably that circumflex stent for the index procedure. The ostium of the circumflex has a grossly undersized stent constrained by deep calcium which was not modified prior to the implantation of the stent. And then we have longitudinal stent deformation in the left main stem. So I think all these points merit a discussion, and then we will hopefully show you how we manage this case in a live setting. And thank you for your time.
Okay. Thank you, Colm. Thank you very much. This is really very provoking case. It's a discrepancy in between what we see in the angio and what you get intravascular. But of course, there is a question which is very important. The lady did well for 4 or 5 years, and she developed late in her history angina. What is that? Is it in-stent restenosis? Is it metallic fatigue of the previously implanted stent? Is it late neotherosclerosis, as Akiko said? How can you interpret what happened clinically?
I think it's hard to say that exactly the timelines are what they are, but I think, for example, the ostial circumflex stent was implanted, did well, came back with restenosis in the ostium of the LAD. The LAD was clear at the index procedure. By the time somebody represents and then they get worked up functional tests, those sort of inbuilt timelines affected things. And because of the complex nature of it, I know after 2016 that this was then a second, this was a second opinion coming to me. So at this stage, she had been back to referring clinicians managed medically. So these complex cases don't always get dealt with in a timely fashion, I find.
Good. David, which would be your interpretation? What is causing angina in this lady? Is the ostium of the circ? Is it the ostium of the LAD? Is this double layers of stents on the left main? Or is all of that?
I think it's all of that, but for me, the main focus now would be the restenosis in the ostial circumflex. I think this is actually, with respect to the angina, I think the most probable reason for making angina.
Akiko, you have seen the IVUS. You are our expert. Is that a case of late calcified neotherosclerosis that developed after 5 years, as you said before, or it's an example of metallic fatigue at the time, at the point of the ostial circ that was probably better 5 years ago, and now it's getting worse and worse?
Yeah, to me, the calcium looks like the behind stent, and although this is like a lot of calcium, but the important of the interpretation of that calcium is each calcium was separate. So it's not like circumferential 360 degree of the calcium. So relatively small multiple calcium behind the stent. So that should be at the time of the stent implantation. That's number one. And second, obviously the ostium circ, even though this is after balloon, it's underexpanded and protruding to the left main. So that leaves us the small stent area to start with. However, this is already about like 5 years after the circumflex stent implantation. So that's okay for a long time for that patient. And then we see the neointima hyperplasia. This is not neoatherosclerosis because the tissue inside of the stent is more likely homogeneous soft layer. So I don't know when this developed, but at least not like very long time ago. So recently developing the neointima inside of the underexpanded stent, that's probably the main mechanism of the current ischemia. And importantly, we see some sort of the crash stent in the left main and also malapose. So this is very important. If you do this type of the old stent, you may consider your wire could be outside of the stent. That's many times happen. But this case, fortunately, it's not. So I think the process is we have to open the old stent to make it bigger. And that's the starting point. And it's very informative IVUS appearance to understand what's happening there.
Can I just make 2 points? And I completely agree with those comments. I think the calcium is behind the stent. Remember, this was an angiographic guided intervention on the first and the second. And we've seen from the angiogram that you can't pick up all that information from the angiogram. The second point is if you look at the stent in the circumflex and the left anterior descending artery, the distal parts are well opposed. So this stent was post-dilated. I've no doubt about that. but it was a failure to modify the calcium prior to the stent implantation, because you've got very good stent apposition at the distal part, and the ostium, the circumflex, which we know is such a difficult area to treat. The deep calcium was not modified at the time of the initial stent, and that's what you're dealing with, is my interpretation of things.
Great.
Agree.
Good. So many good reasoning, very nice examples of interpretations. There is another good data that in 6 years, the lady didn't have stent thrombosis. So somehow it was well done, but there is a progression. There is a progression in time. Now she has angina, you know the problem, and now you show us how you target this issue to solve her problem. So we go to the case performed by Dr. Kennedy and Dr. Hanratty.
Okay, so what we're going to do is we're going to open up the struts into the circumflex, and in terms of calcium modification, I think your options are that we use shockwave, or, because it's quite focal, a cutting balloon to try and modify that eccentric calcification. So what we're trying to do is we're trying to ensure that we have modified that calcium before it's going to be another culotte, isn't it, Mark?
Absolutely. I think this is going to involve a stenting out from the circumflex into the left main, which wasn't done. So an extension of the circumflex stent followed by a culotte towards the LAD.
Yeah, I think we've got in essence a form of a mini crush, haven't we? But without the KISS, the optimization. So, and then we've got the underexpanded stent, which shouldn't cause restenosis, but is a risk of stent thrombosis. So that's the cutting balloon going into the ostium, the circumflex.
Okay.
Do you want to come back a fraction with that?
Yeah.
Okay, good. And this is all about adequate preparation, isn't it? You can see that I went up very slowly there with the Wolverine knot and a little fluoro grab there. Okay, good. So, and then we'll re-image the ostium, the circumflex in particular, just to try and understand whether we have modified that calcium.
Indeed.
I think if we didn't have the mechanical disruption at the front end, you could talk about optimizing this and drug-eluting balloons, but because there's a mechanical issue.
Yeah. I think the longitudinal stent deformation that we appear to see at the beginning of the ostium of the circ suggests that we're going to need to re-stent as opposed to
you run on the IVUS, please.
A drug-eluting balloon application.
Yeah, so I wonder if it's the circumflex stent has come back into the left main further than we think.
Yeah.
And then it has been disrupted with the LAD pullback there. So what we're looking for is evidence that the ostium of the circumflex, the calcium, has been modified, albeit was very focal. And then we'll do a kissing inflation with a 3.5 balloon in the circumflex and a 3.5. So you can see that's already a lot better.
Certainly seems to be.
You can see the multiple layers there at 3 o'clock. That's the multiple layers. Okay. So I'll replay that, and what we'll do is we'll do the kissing inflation, Mark. I'll just play the IVUS and walk through it in terms of education. You still get the IVUS up on the screen, Bran? Okay, so just to recap, the area of interest was here, and you can see the multiple layers of metal, the disruption, the very small area, and the calcification, which is predominantly eccentric. Now, when you look at the circumflex come back, even in the long view, you can see it looks a lot better, and that's the corresponding area, which looks a lot better now with that cutting balloon aggressive post-dilation.
Yeah.
So I think in terms of the circ ostium, we have modified it sufficiently to allow us to proceed with the case. If we hadn't been able to modify it, then we were going to revert to shockwave before putting in another stent. So this shows all the metal in the left main over towards the right-hand side of the screen, but none over on the left. Okay, so what we're going to do now is a kissing inflation. Yep, that's good there. Mark's got the LED, I've got the circ. Okay, good. Yeah, so it's a 3-5-12 and a 3-5-15. 3, 2, 1, and down. So a 3-5-12 and a 3-5-15 NC balloon. You can see the constraint, in the ostium of the circ. So, and of course, we will have all that metal there, which we're not going to be able to completely resolve. So we'll just do the IVUS out of interest from the LED back into the ostium or just into the left main stem. This is coming from the LED back into the left main stem. And you can see the LED stent is not the worst.
No, it certainly appears to be well sized, well opposed.
And there's the circumflex wire. And you can see that fish mouth that we had appearance seems to have been resolved somewhat with that kiss. So the first run, if you remember, there was this appearance here at the ostium of the circumflex with a lot of metal malopposed. And if we come then to the most recent run, so that's the ostium of the circumflex, and there doesn't appear to be the same amount of metal. There is a bit of a carina there. You can see the carina.
I think an ACT, please.
I think we're not going to get a perfect result here because of the constraints. And then in terms of that's that stent from the circumflex. So in terms of the size, we said,
it certainly seems to resolve some of the fish mouth.
It's a 4.5.
I guess it's going to be 5 in the left main.
Yeah, 5. We're going to take a 5.0 NC. So what we're going to do is we're going to take a 3-5-20 Megatron for the LED. We'll go circ first, Mark. Is that your thoughts?
Yeah, I think circ first because I was fine to deal with the...
We'll take a 3-5-20 Megatron into the circumflex pot, optimize the carina, then recross and complete the culotte.
Yes.
I think, Mark, it shows the importance of imaging and understanding if you're doing these complex cases. We've learned so much from the imaging. It's made it quite a predictable case, this. We've been moving promptly through it with no real issues. Okay, so we're going to take the wire out of the LED because we can't jail it behind
2 layers of stents, yeah.
So in terms of the Megatron, it's interesting in that it's probably the first stent which is designed for the aortoosteal with the increased connectors.
10 crowns, yeah.
You closed there?
Yep.
So we don't have to come all the way back to the ostium. That shows it quite well there. Yeah. We're just hoping that this doesn't move with respiration.
Great.
Okay, so let's do a little test there. Great. And then what I do now is go to an LEO 30, please. So the guide is now coaxial. So when we are re-engaging to do a pot, you can see the guide is coaxial and sitting in a nice position.
You can give that another squeeze there at high pressure.
So the 3.5 Megatron will comfortably go up to 6 millimeters in the left main. So it's very useful for this bifurcation work with the overexpansion capabilities. Okay, so we'll take that out and then we'll take that 4.5. We'll do a pot. So as with any bifurcation, next step is pot. So this is a 4.5-8 balloon. 366, that's brilliant. So can you mag up and we'll do the front end and a touch.
Yeah, I think it's good.
Just back a touch, isn't it?
Yeah.
It's moving a bit with respiration. So one of the things you can do is get the patient to hold their breath. But of course what they do is they take a big deep breath in and then your guides all in or all out. Okay.
Throw that.
And then come down to the caudal just to make sure that we're not into the circumflex.
Keep coming caudal, please.
Yeah, just screen.
More caudal. That's great.
Okay, so that's got the left main stem was quite short. So we'll take this 4.5 out. So this next step, I think, is a very important step, which doesn't get discussed enough. And of course, our great friend and mentor, Dave Foley, taught us this, that before proceeding to the next stent, you have to make sure the ostium of the side branch, which we're calling it, has been dealt with, and that the stent is well expanded.
Yeah, I think this is one of the most important steps, because otherwise you run the risk of a not fully opposed stent at the ostium of the side branch vessel, running the possibility of a luminal stent or a luminal wiring. And so I think you need to oppose this as best possible.
And that really helps you with your recross. Yeah. And if you find an underexpanded area, now is the time to deal with it. We can do that whole stent segment.
Yeah.
Of course, we've hit this already, and we're within stent, so it's not like an ordinary culotte. We're pretty confident where we need to go to with our equipment. So it's interesting that guide is now right down the circumflex with the mechanics all been dealt with.
Indeed.
So we can see that the ostium of the circ comes up quite well. So what we do in an ordinary culotte is you have to make sure that there's no edge problem with your circumflex stent, because now is the time to resolve that. Of course, we were landing within stent. We're pretty confident that there wouldn't be. So what we do is we know the wire in the circumflex in a luminal position. We use the balloon, the NC balloon, to keep the wire in the lumen in the left main stem, bring the wire back and redirect it into the LED. Yeah, Mark's going for a distal wire cross, if possible. So Mark's pointing the wire up. Keep it pointing up as he comes back, and then it should grab the struts. Yeah, that's it. Excellent. And then go up cranial just to make sure we're... So this is another sort of slightly cheeky Foley maneuver, is to try and put the NC balloon through the struts for the pre-dilation. And we'll take a 3520 Megatron. Okay.
So took a little pop there.
Okay. Yep, nice. Anyway, Mark, just align the guide. Just go to an LEO 30, please, just to see it first of all. Yeah, mag up, please. Double mag.
Looks pretty good.
Very good there. Yep.
Yeah.
Okay. I prefer to come back to the ostium off the left main stem because it makes this next step easier in terms of the proximal edge.
Absolutely.
Rather than trying to land
in a mid shaft. Yeah.
Okay. Okay, mag up one more, please. Yeah.
Okay.
Okay. So, and this back then, bifurcation technique, pot. Super. Come down, caudal, just make sure we're in the main. I think we're good.
Yeah, I think you in this situation, based on the latest data, you just want to be at the level of the carina, not beyond.
Mm-hmm. So Mark's going to go down on the knuckle into the main vessel and come back, getting the circumflex the way back. And see again, he points the wire down to 5 o'clock, drags it back, and it almost hopes that it will just catch into the more distal strut. Yeah, take a few goes. There we go. And then a wiggle off the wire to get through. Excellent. Super. Just replay that. I think that's a pretty distal. Okay, so what we've got, the 4.0 NC in the LED and a 3.5 for the circumflex.
Yes.
Now, again, we're going to try to, I take the 4.0 NC first, anchor it in the LED and use it to recross. So 4.0 NC balloon, please, the fresh one. Yep. Yep. Recross very nicely. Step 2. Okay. And I think this is one of the main reasons we get stent failure, isn't it? That you don't go aggressive enough with the ostium and the circumflex.
Indeed. I think that's important, that side branch dedicated post-still approach.
Okay. 3, 2, 1. It's worth saying we took a 7 French here, and that allows us the extra real estate to do, use anchor balloons, use additional techniques. Okay. Good. 3, 2, 1. difficulty even filling the vessels at this stage. Looks very good, doesn't it? The imaging here, it isn't really delaying the procedure of anything. I think it in this situation,
it's
expediting because it's removed all the uncertainty.
Yeah, it provides a degree of reassurance.
Okay, so that's the distal circumflex coming more proximal. You can see the multiple layers, and what you'll notice with the Megatron, especially in the long view, is it's a much more parallel. You see that appearance in the long view. You can almost tell the Megatron. So that's well expanded, well sized for the vessel. That, I suspect, is coming into the ostium, the circumflex. Remember, we've got all the old metal from before, so we are going to be constrained from that. And then, yeah, I'll do that. And then in terms of the left main, we want to make sure there's no longitudinal stent deformation. Excellent. So what we'll do is I'll do some measurements there, and Mark will put the probe down the LED. Okay, so we'll stop. Just stop recording.
Yeah, sorry, apologies.
Okay, so the circ ostium, what did we say it was at the start? It was 2 point something? It was 5?
2.2 of a MLD.
Diameter. Think there, Brad?
I didn't see the area. It's probably 4.5, was it? 1 second now. Don't move there with that. I'm going to pop it down the other vessel.
So an area of 8.
How was that last ACT, guys?
In terms of the ostium and the circumflex.
Oh, okay. So give her 2.5.
No, it's okay. I think we're okay.
Oh, you gave it, did you?
No, we're okay. Oh,
sorry, Colm.
It's 266. I think we're okay.
Oh, yeah, 266. Sorry, so it's 166. Apologies.
It's a generous 15, isn't it? But it's in that sort of ballpark.
In the 14.6 as well,
14,
into the.
So an area 14 in the left main stem.
So this is LED back to left main.
Yep.
Just after the corona.
So Mark, I notice you're the same. You know, we've done an angiogram to show that there's flow down the vessels. So we don't do further angiography. If we flow down the vessels, we're then looking for distal edge, looking at the corona, we're looking at our minimal stent area, and then we're looking at the ostium for longitudinal stent deformation. And if we have fulfilled the criteria and all those, then we don't do further angiography. And what I do is just take everything out at that stage, take the guide and everything out, and no more angiography.
Got a lovely figure of 8 there at the corona.
Yep, that's the corona there. Looks very nice, doesn't it? So this is the circumflex and the LED. Looks very nice in terms of mechanically a much better result. So that's the distal left main stem. We'll do a trace assist, see what we get. It's more than that. So we're over 10. So according to Axel, the chance of stent thrombosis is 0. The chances of restenosis, you're talking about low single digit.
Yeah, you certainly could.
Right here.
Down a bit, yeah.
So we're going to get over 11 just by playing around with it here. And then the other point is the front end. The front end, the struts. You can see that it has come into the aorta.
And no longitudinal stent deformation there.
So that's out into the aorta. There's no evidence of longitudinal stent deformation. So I would just take everything out in one go. Okay, so in terms of wrap up, thank you once again for asking us to take part in this session. I think we fulfilled a brief, which was an educational case, which was stent failure largely based on undersizing, not dealing with calcium before implantation of stents, and then a failure to recognize a mechanical issue and not dealt with in terms of kissing inflation or optimization.
Well, first of all, allow me to congratulate with Mark and with the colleagues from Dublin, because this is really a very elegantly performed case. We have seen the baseline imaging and the final imaging, and it's totally a different story. There are many points to discuss. I will try to go fast. We have 10 minutes to develop this, And I will start with David. David, this patient had stents already in the bifurcation of the left main LAD, but for some reason, the stent on the circ collapsed. We said might be the metal, might be the neoatherosclerosis. Do you think that the stent platform plays a role here? They selected a dedicated Megatron stent and the final result is overwhelming. What would you comment? I mean, is anything stent would go the same way or there are differences?
I think there are differences. We know this from a lot of bench studies which evaluated this, and especially in this case, and this was within the case, the Megatron stent shows his unique possibilities to treat left main because you have a good radiation exposure, you have a radial strength that helps, especially when there's an old stent in which collapse, to hold it open. And on the second point, you have this unique possibility of an over enlargement at the ostium of the left main. And therefore, you are able to build such a tapered vessel that you need in this case. And so I think in this case, this was a perfect lesion for the Megatron.
Okay, so the stent platforms plays a role in calcified lesions. I think we all agree with that. Akiko, a different point of view. Our colleagues do the IVUS, they see the problem. There is not much neointimal proliferation, but there is neoatherosclerosis, and they don't consider using drug-eluting balloon. Do you think this would be an option after adequate expansion at high pressure, doing locally applied antiproliferative therapy with drug-eluting balloons?
I do think so, because retrospectively speaking, this is focal, meaning the main issue was mechanical, meaning the start with and expansion probably at the time of the stent implantation. Plus, we don't know, but possibly some sort of the chronic stent recoil, or we don't know. But those are the major factor. And then we remember the neointimal population was not too many, a little bit, right? So I think that's one option. Based on the IVUS imaging, I do think so.
Yeah, I agree. I agree with that. I think if the stent looks perfect mechanically, then you need the anti-proliferative effect and a drug-eluting balloon. But I think if you've got a mechanical issue or a first-generation stent, then you need additional stent. And here, I think we had several mechanical issues to resolve.
Okay, Colm, any role for physiology in assessment the severity of this lesion?
So I think we had the functional test of the MRI beforehand, which said there was ischemia in both territories. And then it's to do with the mechanics. So the reason we went for a 2-stent strategy, so let's say, for example, this was, if you had a time machine and went back to this lady's index, admission, I think it would have been a single stent from the circumflex back into the left main stem. The reason we were committed to a 2-stent strategy, and remember that's then what a 4-stent strategy for this lady, was that we had such bad mechanical result from the index. And the only way I could see to resolve that was to convert that to a culotte. You could maybe argue about a circumflex left main and a form of a mini crush. But I just wanted, this is a young lady, she's had several complex procedures. Mark and I just wanted to give her the best chance of a durable result. The areas, Akiko could talk better on this, but the area of the circumflex was 8, the distal left main stem 11, so those are very good areas, and the chances of a mechanical failure for this lady are low.
Great. So you anticipated one of the questions from our colleagues participating in the chat, because this was exactly one of the points. You decided beforehand to go with 2-stent strategies with a culotte, which is a very European style for treating bifurcations in the left main. The other option could have been reinforcing the ostium of the circ and leaving the LAD, which looked quite well. Do you think that after what you have seen with your IVUS, you did the right thing, or you might consider staying with only 1 stent?
Well, I think as you've alluded to, we're big fans of culotte, and that was the influence of David Foley on Irish cardiologists. And we published a study, Celtic Bifurcation, looking at 200 1-1-1 bifurcations. And if you do culotte stenting well, as Professor Foley taught us, target vessel failure at 24 months is 2%. But the key step in that, and that's why the DK double crush works so well, is that you treat the ostium of the side branch very well with a post-dilation before you implant the second stent. I think it's now called a double kiss culotte stent. Is that really how you would refer to it? But by treating the ostium with that side branch and finding out if you've got a mechanical issue before that second stent goes in, translates to these very durable results.
I could not agree most with you, because I absolutely agree that culotte in these large vessels, it's very appropriate. David, any different opinion, or you also support same technique?
No, I completely agree. When I saw the first case, I thought about whether you could do DK crush, but with respect to the longitudinal stent deformation and the old struts that were in the left main, I think a long street, as you build it by making a culotte stenting, is the perfect solution for long durable result. And this is a young lady, so I think this is the right technique, perfectly done, and really the best what you could do for this patient.
I think it's worth saying we got a bit lucky with the wiring. You can imagine how, if the wire, for example, into the circumflex had gone in and out of struts, or the wire into the LED had gone abluminal, you could have got into a world of pain. So I think we did get a bit lucky with the wiring. We took a lot of time and low threshold for using dual lumen catheters to recross, but you could have got into a lot of trouble at the start of that case with all that metal floating around.
Good. We have another question. Some of our colleagues wants to know, Colm, you mentioned this in your presentation of the case, that there might be some longitudinal stent platform deformation. And this is what David said too. They ask, what do you intend for longitudinal stent deformation? How do you recognize it, and how do you treat it eventually?
Yeah, well, recognition is the key, and it's whenever you've got an appearance. So the stent should be, circular. So you should have stent at the top of the vessel and stent at the bottom of the vessel. We had stent up on the top of the vessel, but none down at the bottom, and that usually means part of the stent has been deformed. As long as you recognize it and post-dilate it and oppose the stent, it's got no consequence. But in this situation, you could see several things. You could see a crushed old stent at the 6 o'clock, and that longitudinal stent deformation in a stent which was floating in the left main stem. Like Akiko can refer to this in terms of XL, the longitudinal stent deformation translated to what, a 25% miss in those patients where it was identified on the IVUS but not treated. Akiko, what's your thoughts on it?
Yeah, I think the recognition is the most important. In the XL trial, we see the 6.5% of the cases having the longitudinal deformation at the end of the procedure, meaning probably operator didn't recognize. So I think we have to expect, if you do left main stenting, you may have the chance to have even angiographically perfect. So first you have to look for, and how? You put out the guide and to see ostium, because most of the time deformation occurred at the ostium, right? So the recognition is the most important. And second, as you said, correct, meaning like the how to deal with. And when we have the longitudinal deformation, two things. One is because the deform, you have multiple layer at the ostium. In such, your final stent area at the ostium could be smaller than you originally had. So you have to open up again. That's one. Second, because of the longitudinal deformation, sometimes you may miss the original lesion because your stent is shorter than the original. So those two things you have to confirm. And then most of the time, just balloon more, and that solves the issue.
Wow. Thank you. Thank you, Akiko, very much for sharing with us all this knowledge that sometimes is a little bit too sophisticated for interventionalists doing things quick and dirty, as we used to say. I think this has been really a great discussion. There is a very short question I will address to the operator regarding the dual antiplatelet therapy with this stent platform in a young lady with culotte after 2 stents.
I would quite comfortable to stop dual antiplatelet therapy after 4 weeks in this lady. This is a abluminal polymer stent, so 4 weeks would be fine. the recommendations and guidelines are more than that. But if she had to have urgent surgery 6 weeks from now, I'd have no problem, because we've got an IVUS guided procedure. The stents are well sized, well opposed. I'm pretty confident that she will get stent coverage within 4 to 6 weeks. So if there's a suggestion of you're talking about lifelong dual antiplatelet therapy, absolutely not. Most of the platforms nowadays have an indication for 4 weeks of dual antiplatelet therapy.
I absolutely agree. David, do you agree with the short-term DAT, Akiko and David? Yes. I think the most important thing is the good stent position and the large lumen after this perfectly performed procedure. Okay, from the studios, do we have time for the final conclusions, or we are done? 30 seconds. Yeah, very briefly, when we talk about calcified lesions, we are concerned about complications. Rupture, bar entrapment, dissections, low flow. Please allow me to remind you the most frequent complication is unsatisfactory stent expansion, suboptimal results, and the patient pays the toll for that at the long term with restenosis and thrombosis. So, imaging is the key. Thank you very much.
Thanks, guys. That was a good session.
Thank you. Bye.